Hello, everyone. I am Linda Scott. I'm the Dean of the UW-Madison School of Nursing, and I am pleased to welcome you to the 19th Annual Littlefield Leadership Lecture. This is a wonderful tradition for the school. It's an important legacy for the profession and a great opportunity to foster dialogue among those who make discoveries, enhance systems, and improve health through research, education, and practice. We have more than 350 individuals in attendance here in Cooper Hall, and at least another 50 who are attending through our live video stream at UW Eau Claire on their campus. The Littlefield Leadership Lecture Series began years ago to honor Dr. Vivian Littlefield. Dr. Littlefield served as Dean of the UW-Madison School of Nursing from 1984 to 1999. She was the National Chair for Nursing for the American Red Cross with expertise in women's health, nursing care delivery, and the impact of alternative approaches to care on patient outcomes. Dr. Littlefield's contributions are significant. She is a fellow in the American Academy of Nursing and a member of the American Nurses Association and Sigma Theta Tau International. Dr. Littlefield has been a dedicated mentor to countless nursing students and nurse researchers, as well as an advocate for nursing leadership. I'm delighted to have Dr. Littlefield with us tonight. Please join me in welcoming our honored guest, Dean and Professor Emerita Vivian Littlefield. I would also like to take a moment to thank the individuals who have helped to make this event a success. Thank you to our sponsors, UW Health, Edgewood College of Nursing, and Greg and Carol Griffin for their support. I would also like to thank the Friends of Littlefield who have sustained this lecture series through their long-standing generosity. Would the Friends of Littlefield please stand? And I would like to thank all of our School of Nursing colleagues who've worked hard behind the scenes to prepare for this evening. And last, I would like to thank Lieutenant Commander Yvonne Santiago, who worked closely with my office to make tonight a reality. Thank you very much. We thank them, and we thank you for choosing to join us tonight. We hope the lecture sparks conversation this evening and in the weeks to come. I invite you to join us for a reception in Curran Commons just outside the auditorium immediately following the Q&A portion of our evening. And now, it is indeed my honor and privilege to introduce this year's Littlefield Leadership Lecturer, Deputy Surgeon General, Rear Admiral Sylvia Trent-Adams. As Deputy Surgeon General, Admiral Trent-Adams advises and supports the Surgeon General in the operations of the United States Public Health Service Commission Corps and in communicating the best scientific information to advance the health of the nation. She has served our country in previous roles, including Chief Nursing Officer of the United States Public Health Service from 2013 to 2016, and Acting Surgeon General from April 2017 to September 2017. In all of her positions, Admiral Trent-Adams has worked to improve access to care for poor and underserved communities. As a clinician and administrator, she has had a direct impact on building systems of care to improve public health for marginalized populations, both domestically and internationally. Admiral Trent-Adams received her Bachelor of Science in Nursing from Hampton University, a Master of Science in Nursing and Health Policy from the University of Maryland, Baltimore, and a Doctor of Philosophy from the University of Maryland, Baltimore County. She became a Fellow in the American Academy of Nursing in 2014. Her impressive portfolio includes numerous awards for leadership and contributions to nursing, public health, and healthcare delivery. She is a recipient of the American Academy of Nursing Civitas Award, the American Association of Colleges of Nursing Lois Capps Luminary Policy Award, and the International Red Cross Florence Nightingale Medal, the highest international honor bestowed upon a nurse. Please join me in welcoming Deputy Surgeon General, Rear Admiral Sylvia Trent-Adams, to the podium.
Good evening, everyone. How are you? This is quite an impressive crowd. I tell you, I'm so, as my daughter would say, I'm shook, okay? This has been an exciting day for me. It's been a long time since I've been here in Wisconsin, but in my former life as a HRSA employee, as I was serving in the Ryan White program, I was a branch chief for what they call the Western region, and it was from Chicago to Guam. And part of that region encompassed the state of Wisconsin, and I spent quite a bit of time in Milwaukee, but also had some trips to Madison and to Eau Claire. So thank you for the invitation to be here, and welcome to those of you who are joining in Eau Claire. I want to thank you, Dean Scott, for inviting me, and I want to thank Teresa Mulder for her assistance in working with my colleague, Lieutenant Commander Santiago, to make it possible for me to be here. And I am so honored to meet you, Dr. Littlefield. Your reputation precedes you. You're a rock star, and you're one of the superstars of nursing, and it has truly been an honor and a privilege to make your acquaintance. So tonight, I want to speak to you as an honor. It's an honor to speak to you as a part of the Littlefield Lecture Series. And some of the folks who have spoken at this podium before on this particular event have been the heroes and sheroes of nursing. And I know that there's a high bar, so I'm going to do my best, okay? I was an Army nurse at one point in my life, so I just want to say that I will do everything I possibly can to do what my mother taught me about making a great speech. Be brilliant, be brief, and be gone. Okay. So, thank you, and I would like to talk tonight about understanding public health as the culture of health. And as a part of this presentation, I also have a responsibility to let you know that I have no financial disclosures that would prohibit me from doing this talk. I have no potential conflicts of interest with this particular presentation. So, first of all, let me just talk about what I want to share with you. You know, in the United States, we've made great strides in improving health. And in our nation, over the last century, we've had tremendous improvements in access to care, but we've also had significant improvements in the quality of care. Okay, Doug. And part of the challenge is understanding that we've had precision medicine in this last century develop, vaccine research, drug development, amongst others that have impacted our efforts in improving chronic illnesses. People are living longer, but we are falling short in a number of ways. We want to make sure that everyone can have optimal health, that they can reach equitable distribution of health care in their community. And we also want to make sure that every sector of the population can be heard as a part of the healthcare community, as the voice of their own advocacy efforts. So today I will discuss some of the factors that we need to address in order to achieve better health. My objectives for tonight's presentation is very straightforward. This presentation will provide a brief overview of public health and its link with community health. I will describe the impact of public health on communities. I'll briefly examine the intersection between public health and health care, and the impact of the social determinants of health, and identify comprehensive models of health care that impact our communities. And I will be brief. So, I want to talk about, did I go back? Okay, there we go. I'm sorry, I can't see this from here now. So, what is public health? Well, according to Winslow, public health is the science and the art of preventing disease, prolonging life, and promoting health through organized efforts and informed choices of society, organizations, public and private communities, as well as individuals. Now, community health is a little bit different. is defined by Goldman et al. As a multi-sector and multidisciplinary collaborative enterprise that uses public health science, evidence-based strategies, and other approaches to engage and work with communities in a culturally appropriate manner to optimize the health and quality of life of all persons who live, work, and pray and play in a defined community or communities. Communities are an essential piece of public health. Investing in safe and healthy communities does matter. Today in the United States, your zip code is a stronger indicator of your health outcomes than your genetic code. Therefore, public health is directly linked to community health at all levels, whether it's at the federal, state, or the local level. I want to talk about the core functions of public health. Now, this has been somewhat of a challenging area for us over the last few years because you've seen public health redefined with more and more emphasis placed on environmental health and the community health. The definitions changing, becoming more encompassing. But the core functions of public health, as defined by the Institutes of Medicine's landmark paper entitled The Future of Public Health, are assessment, policy development, and assurance. Now, what does this mean? We want to systematically collect and analyze data, promote the use of scientific knowledge based on policy and decision-making that ensures services are provided to most vulnerable populations and to underserved populations in the most equitable way possible. The Department of Health and Human Services used these as a paradigm to creating the 10 essential public health services. If we were to observe these services, this is a framework for creating a sustainable public health system which concentrates on the patient-centered care model, but it does focus on the most important component of what we want to do as clinicians and policymakers, which is to improve the health and safety of a given community. So these are the essential public health services. So we can use these in different ways to make sure that we can ensure the use of the services that we do have available in our community in a way that is more straightforward. And historically, public health has been significantly underfunded. When you look at the global context of how we spend our healthcare dollars, the vast majority of our healthcare dollars are spent at the end of life. We spend very little on the front end of prevention. We're learning more and more about how the investment in the healthcare delivery system and the return on investment of the delivery system, where the imbalances are and where we need to make those challenges more obvious to the consumer, as well as those who are underserved and in need of great services. So as we look at the lack of investment in these key determinants of health, there's been detrimental impacts on our communities. We know that if we look for challenges, we can find them at every corner. We must combine traditional models of care and health interventions as well as non-traditional. I like to always say, if we keep doing the same thing we've been doing all these years, nothing's going to change. The first sign of insanity is doing the same thing over and over again, expecting a different outcome. So as clinicians, we know that in order to change a patient's social behaviors, we must first influence and change behaviors that improve factors in their overall community. We're products of our environment, so looking at the environmental factors as it relates to the individual can have a significant impact on how we view the health and health challenges of a given community. In order to improve our health, we must invest in factors outside of the healthcare delivery system. So let's look at the role of health and health care. If we use more of those resources, we must not forget that although there are differences between public health and health care, as we note from this table from the CDC, health care and public health are complementary. When we work collaboratively, all people benefit. Public health is not just clinical care. It's everything that influences and impacts one's health. We cannot take care of patients without an interprofessional team, nor can we take care of patients with only healthcare providers. One of the most underserved and unrecognized challenges with the poor and underserved is housing. As we like to say in the Ryan White HIV program, housing is healthcare. If someone is unstably housed, they're more likely not to have access to healthcare. They're more likely not to be insured. They're more likely to have chronic illnesses and to lack access to a routine healthcare provider. Healthcare is a partner in public health. We must not forget that although there are differences between public health and healthcare, there are significant differences as we go across communities. As we discuss communities and methods for improving our overall health as a society, we need to address current barriers to health and healthcare as we can now look at this from the research. Researchers, clinicians, and public health professionals can overcome some of the challenges that we face in the communities that we serve. Some communities are facing significant challenges as well as disparities that have never been fully understood, not by healthcare providers, not by policymakers, and definitely not by appropriators. So what are some of the barriers to healthcare and to health? Well, we must first define these two terms. Disparities in health and healthcare are related but not synonymous. A health disparity refers to a higher burden of illness, injury, disability, or disease, mortality in one population group relative to another. So we typically look at the minority population and the non-minority population as a comparative analysis. A healthcare disparity, however, typically refers to differences between groups in health insurance coverage, access to and the use of care, and quality of care. More specifically, health and healthcare disparities often refer to differences that cannot be explained by variations in healthcare or healthcare needs, patients' preferences, or treatment recommendations. Several related items such as health inequity and health inequality often are used interchangeably but mean very distinctly different things. Differences that are socially determined or deemed questionable or unavoidable or unjust brings into question health inequality and health inequity. So what are some of the factors that contribute to disparities? This is often a very challenging question to answer because a complex and interrelated set of individual and provider and health system and societal environmental factors make up this entire nexus of challenges or forces within health disparities. And these factors contribute to disparities in health and health care. Environmental factors significantly are growing as an impact. If you look at the incidence of asthma in young children, we know that a lot of these triggers are environmentally based. Yes, some of it's genetic, but most of it, according to the science, look like they're environmentally triggered, but also environmentally exacerbated over time. So how do we define the role of the healthcare provider? And how do we look at individual factors from a different perspective? Individual factors include a variety of behaviors for maintaining a healthy weight for individuals who are obese. We know that there's a complex set of provider as well as individual and health system environmental factors, but there are certain factors that have more of an impact. Provider factors encompass issues such as provider bias, cultural and linguistic inequity, and also patient and provider communication. Now I want to stop there for a second because we talked about communication earlier in one of the round tables, and I want to share with you that one of the most important aspects of healthcare is communication, and that's communication at every single level. Yes, we talk about it at the interpersonal relationship between the patient and the client, or the patient and the community, and the patient and the provider. But what about the patient and the advocacy groups? What about the clients that we see in large groups and in a group setting, and providers who are making decisions about a model of care? Well, there are so many things that we often miss, and I know that over time we've seen many different tools being used to improve communication. Now I'll talk about the millennials. How many of you know that have iPhones, have Samsungs, have smartphones? Okay, everybody in the room, right? Well, you know, in the military, there was a survey done about 3 years ago to look at how we measure health disparities and healthcare disparities. And what we learned is that, well, everyone in the military has health care. It's an entitlement. You wear the uniform, you have health insurance. But not everybody accesses the system the same way. We learned that millennials, their first source of healthcare information is on their iPhone. Instead of going to sick call when they have a fever, they consult WebMD. instead of going to their provider when they are having what they think is a level of increased anxiety or stress-related illness due to being in a deployment situation, they consult their iPhone or they consult their WebMD or whatever the resource or the new app is of the day. And that's very challenging. It creates gaps in knowledge for an individual who may try to, as we say, self-diagnose. Now, for providers, that's one thing. But for an infantry soldier who's holding an M16 downrange, it creates a whole new dynamic of risk. So it creates a disparity that we don't often think about. Now, in the community where there are poor and underserved members of the community who don't have access to health care, who are using resources and tools, we need to better understand those tools. Now, on the military side, it's an easy fix because we have command authority. We can direct them to go to sick call. We can do all these things, and they have access to care. In poor and underserved communities, it's a very different dynamic. We can't change that curve as quickly, and we have to drill down a little bit more to find out what the real problems are, or these nuances and that we don't understand, that we need to figure out how better to serve them and to bridge these gaps between health disparities and access to health care. So what are some of the factors associated with health disparities? And disparities in health care not only affect the groups facing disparities, but can also limit overall improvements in quality of care, as well as health care for the broader population, and it increases costs, typically unnecessary cost. Addressing disparities in health and health care is not only important for us from a social justice standpoint, but also for improving the health of all Americans by achieving improvements in overall quality of care and population health. Moreover, health disparities are costly. It costs more to treat the patient in the emergency room and in the ICU than it does in an outpatient setting or with a home visit. Addressing disparities in health and health care is not only important from the social justice standpoint and from a clinical care standpoint, but from a population health standpoint. Health disparities not only are costly, but they are significantly increasing the gap between who has health care and who does not. So the haves and the have-not will continue to be exacerbated if we're accessing care from a chronic care model for a chronic condition through an emergency room model. One analysis estimates that approximately 30% of all direct medical expenditures for Blacks, Hispanics, and Asians are excess costs due to health inequities. Studies also show that for individuals to access health care from where they currently live is significantly decreasing for them if they live in rural communities or if they are from minority represented populations. So what are the social determinants of health? Basically, they're education, economic stability, food, health status, healthcare system, neighborhood, physical environment. These are the social determinants of health. We need to address gaps in these areas by improving population health through healthcare reform, such as many of the national health insurance programs. And one example that I like to use all the time is the Massachusetts model of healthcare reform. At the national level, we had the Affordable Care Act. There's also county and cities that are making significant changes in the delivery models for how they provide access to care for their populations. We need to look at how we are using the National Prevention Strategy to expand the scope of services to meet the needs of individuals and populations. It addresses the social determinants of health, but it also looks at the models of delivery that are available within the communities where patients live. And there's a lot that's being done on changing the way in which we address gaps. And we're trying to improve the population health. We're trying to make changes to the healthcare delivery system. But healthcare reform will continue to be an ongoing process in this country. And I know that in this country, we do not like drastic change. There is nothing worse that we hate than ripping the Band-Aid off. That doesn't happen here. Incremental change. And if you want to be realistic about this, healthcare reform started in the 70s with President Nixon. If we want to go even further back, we can go to the 60s, Medicare and Medicaid, community health center programs. Incrementally in the United States, we've been creating these buckets of activities that relate to getting to, hopefully at one day, universal health care or universal coverage or some model of care where everyone can access some level of health and health care. So how are services delivered? And this is a really challenging area because many individuals feel that they want to go to the one doctor they want to go to, which may be in their community or 3 states away. There are people who travel long distances, especially if they have a chronic disease that may be a pre-existing condition that may lead to stigma or isolation, or HIV is one good example, but other STDs and other chronic diseases have the same level of stigma. And so we need to look at how services are delivered in a delivery system in totality to be able to understand how best to address the population healthcare needs. Patient-centered services are critical. If we don't address the needs of the patients that we serve, we're not doing our job. Case management for the comprehensive model of prevention to death. Looking at innovative models of care delivery, which we'll discuss a little bit later. Using telehealth to this full optimization. Electronic health records that talk to multiple systems, and having systems of care that allow you to track data on your individual patients over time. Now, the services that we typically consider a part of the healthcare delivery system is a very narrow focus. So in the tertiary care model, you know, when I came out of nursing school, I'm going to date myself here, but I'll go out on a limb. Most of us thought that when we graduated from nursing school, we were going to go into a hospital, we were going to work in med-surg, oncology, ICU, ER, wherever. But it was typically, when you asked a nurse where were they going to work, they were going to say, I'm going to go work in a hospital, inpatient. How much has care changed? Most of the focus now and the way forward, and even now, is public health and community health. Patient care is moving from outside the tertiary care facilities to the community. And we don't always know a lot about the community. The community-based care is the biggest bang for the buck. Any nurses in here interested in public health or working in the public health arena? Excellent. Okay, look at your future rock stars, because they're going to be the CEOs of these companies. They're going to be managing population health over time. And part of the challenge that we are focusing on at the federal level is, what do we know about the community? What do we know about populations? And how do we get this data? How do we use this information to build a knowledge base to provide the appropriate care? Now, how do you define a community? How do you define population? What population are you going to focus on? These are critical discussions that need to be had at the highest levels, because I will tell you, I learned the hard way, just because you think you know a population, you don't really know a population. I thought I knew rural until I went to Appalachia. I said, uh-oh, I'm in trouble. I thought I knew rural until I went to South Texas. That was rural, but it wasn't the rural that I knew. And there are distinct differences and bias that every last one of us take with us to every single encounter, every single conversation with a patient, and every single community health center that we walk into, and we need to own that. We need to recognize the bias and the view of the world that we all have about a population or a community, and be able to right-size that to best meet the cultural and the linguistic and the values and belief systems of that community. Otherwise, we will never get to a place where we're able to provide that comprehensive array of services that are patient-centered and whereby we can provide comprehensive case management that meets the specific needs of that community. Now, I want to talk about a couple of things that we've been doing at HHS, and this is going to go into a couple of different directions. I keep walking away from the mic, I apologize. So the first thing I want to talk about is Public Health 3.0. In 2016, the Department of Health and Human Services launched Public Health 3.0. But before I describe Public Health 3.0, let's discuss 1.0 and 2.0. This initiative continued efforts from Public Health 1.0 and 2.0. Public Health 1.0 defines the period between the late 19th century and the early 20th century, which launched our modern public health system, the system that most of us were trained in nursing school and even today. During this time, you saw us improve sanitation, food and water safety. We launched prevention tools such as vaccines and antibiotics. Public Health 2.0 was a result of the infamous 1988 IOM's The Future of Public Health report. During this time, public health was in disarray. We made significant improvements in science, but we lacked the connections between theory and practice. You know, that moving research from the bench to the bedside? Well, between academia and the field work, there's still a lot of gaps that existed in 2.0. We forgot the fundamental mission of public health, which was to create conditions which people can be healthy. This really propelled us as a society, and we made significant improvements at the government level to increase our performance standards in public health practice. Benchmarks and metrics and GIPRA reports and all kinds of data collected from individuals who interconnected with the federal government. Now, in Public Health 3.0, which was led by Dr. Karen DeSalvo, the former Acting Assistant Secretary for Health, which refers to a new era of enhanced, broadened public health practice that goes beyond traditional public health department functions and programs. Ultimately, the goal of this program is to create a strong local public health infrastructure in all communities, which is focused on building an equitable health promoting system. We want to focus on prevention and improve our system from a sick care system to a system of prevention. As I say, going from a sick care system to a system of health. And we achieve this through leadership and workforce. Every community needs a chief health strategist beyond the capabilities of the community, the chief health officer, someone who can be a force multiplier, the leverage point, if you will, for community health at the local level. We need strategic partnerships, infrastructure, and accreditation. We need data, metrics, and analytics that are real-time, translatable, and mean that there is an understanding of what the community health needs are in that population. We need sustainable and flexible funding. Increase funding for public health to cover the cost of delivering services and the infrastructure to build that system. DeSalvo et al. Concluded that to solve the fundamental challenges of population health, we must address the full array and the full range of factors that influence a person's overall health and well-being. Education, safe environments, housing, transportation, economic development, access to healthy foods. These are the major determinants of health, comprising the conditions in which people are born, live, work, and age. Those are the conditions of that environment. So let's look at the history of the Healthy People Initiative as another landmark activity within HHS. In 1979, the Surgeon General released a report entitled Healthy People, the Surgeon General's Report on Health Promotion and Disease Prevention. This report, released by Julius Richmond, Dr. Julius Richmond, highlighted changing our nation's health policy to emphasize disease prevention. So we've been talking about this for a little while, right? Okay, 1970s, right? The report was groundbreaking because it encouraged people to take more personal responsibility for their health through exercise, nutrition, and other behaviors, to include smoking. This was a big launch for HHS's Healthy People Initiative. And in every 10 years of the initiative, we've revisited the principles shared by Dr. Julius Richmond that were initially shared in that groundbreaking report. So what are the objectives of the Healthy People Initiative are that we would identify a health improvement priorities nationwide. So this is encompassing all the needs of the entire country. Increase public awareness and understanding of the determinants of health, disease, and disability of opportunities for progress. Now, I don't know if any of you have seen the Healthy People 2030 platform, but it's the format is the same each of the 10-year blocks. But those metrics are really, really important because initially they were very obscure. They were not really measurable. And over time, I'm really pleased to see that we've started to pay attention to the metrics so we could see outcomes. We would know that return on investments were related to some of the things that we want to focus on in improving health and public health. Without numbers, you really can't track your progress, and that includes grades. Trying to see if you're awake. All right. And we know that we provide measurable objectives and goals that are applicable at the national, state, and local level, but it's so important for us to understand how we know about, that everyone in the community knows about these measures, because it affects every single one of us sitting in this room, but also the patients that we serve. We wanted to engage multiple sectors to take action to strengthen policies and improve practices. those practices that are driven by the best available science and knowledge that we have. So the evidence is that if we know what the issues are, and we can find a strategy to address these issues, we need some smart people to come up with metrics that we can start to target over time and build out interventions to help us to solve those problems. But many of us don't always understand how those metrics play into the overall campaign of public health and prevention. So we must look at the critical research, the evaluation, and data collection needs of a given community. And let me just say this. We thought that in multi-drug resistant TB, that was one of my big projects when I was in the Army. I thought, okay, we have done so much work in TB. We've been able to diminish this severity of disease. The incidence has significantly gone down. And now here we are talking about multi-drug resistant TB running rampant in some countries, and now being faced with it in some communities in the United States. Now I want to talk about one of my greatest joys, which is the Ryan White HIV/AIDS program. The Ryan White Comprehensive AIDS Resources and Emergency Act, also known as the Ryan White Care Act back in the day, we now call it the Ryan White program. This was one of the greatest joys because we knew that we had a problem in the 1980s, early 80s, into the 1990s around HIV. And I want to talk about HIV a little bit because it's the one thing I can talk about, okay, with some credibility. There are not many, but that's one of them. So I want to talk about, what happened with this public health crisis. We knew that we had a lot of people who were infected with HIV. We knew that we were at a crisis point in the big 5 cities. We knew that people would continue to die. No one wanted to take care of them. And there was nothing in the formularies and the pharmacies that was proven to work. When I came into clinical practice and nursing, we had one drug, and that was AZT. And for a lot of populations, it didn't work so well. We saw a lot of drug resistance. We also saw a lot of multi-system toxicity. So in 1990, Congress enacted the legislation that created the Ryan White HIV/AIDS program. And the program is administered by HRSA, the Health Resources and Services Administration. And the goal of the program is to improve the quality and availability of HIV care and treatment for low-income, uninsured, underserved people living with HIV. Now, this program is very unique in that by law, there's a program for the community level. There's a community-based program. There's one for children, infants, youth, and families. There's one that funds states, and there's a part of the act that funds cities. How beautiful is that? But in every single component of that legislation, initially titles, now the parts, were required to have a community advisory board. The community had to be involved. Consumers had to be involved, and they had to have a consensus process by which they implemented the decisions that were made by that board. Care, prevention, treatment, outreach, everything had to be decided through some community-based process. Now that's it's an easy conversation for some communities, but not so much in others. Because as you may remember, in the beginning of the epidemic, so majority of the cases were in gay white men. We did not know that immediately the population would shift to other underserved populations. Let me tell you, it was a knockdown, drag out trying to convince people to change priorities. Once you had funding streams established on certain services by certain populations, when the populations changed, the representation within the community had to change by law. So it was very interesting to see how these changes evolved over time. And I want to spend some time here because it's important to understand that as your communities change, the stakeholders must change. If you're going to represent the views and the diversity of those people who are being impacted to be fair, to be equitable, and to be representative, you must have the diversity of all sectors of that population who are being impacted. So in the HIV community, you had to have gay white men, you had to have people of color, you had to have the homeless, you had to have injection drug users. Every sector, every population and subpopulation that was impacted must be represented in some way, shape, or form in that advisory process. Now, the Ryan White program was challenging in some ways because the framework was based off of a public health approach. And not everybody operated at the community level in that way. So to have a community advisory board come together with physicians, local leaders, elected and otherwise, community-based providers who may have been nonprofits, but also consumers, to come to the table and to make a decision with the best interest of the population involved was quite challenging, because in some cases the physicians felt they knew best. In other words, in other cases the patients thought they knew best. In some cases, nobody knew what was best. So we had to come up with some rules of engagement. So everyone needed to come to the table with humility and check their egos at the door, because the only way that care was going to be improved, the only way that people were going to be served so that we could decide where best to spend these limited, finite resources, we had to have some level of collaboration. And that's what has led to the Care Continuum. So the Care Continuum in the Ryan White program, and I'll talk through this a little bit, is that there are a series of steps that a patient with HIV will take from the initial diagnosis all the way through successful status of being virally suppressed. Now, this is no small feat, because let me tell you, someone who's using drugs, living on the street, has no money, no job, and no place to live, they're not really interested in coming to see their provider to get medications or anything else. But by having case managers, outreach workers in the hospitals, and on the streets, and also pharmacists who are educating, you create this comprehensive model of care that allow you to get someone diagnosed on the street through a mobile van, which is paid for by the program. They can get linked to care by having a direct referral from the mobile van to a provider within a week. And then they can get engaged and retained in care by having ongoing communication and connection to case management and outreach. And you get them prescribed on antiretroviral therapy after you have their labs and you've done genotype, phenotype, and all the diagnostics you need to do within the care of the program. And then hopefully we will get them all virally suppressed, because that is how we're going to end the era of HIV/AIDS. Now, this is not easy, but it can be done. In the Ryan White program, we know that the viral suppression rate ranges between in the 80s, 80 to 85%. And the national average is 50%. Now, let me take you to Malawi, where we have our PEPFAR initiative. Now, Malawi is very poor, is rural, and is very underserved, but the viral suppression rate in Malawi is 92%. Now, if we can do it in Malawi, we can do it here. We just need to put the pieces of the puzzle together. I'm almost done, but I want to say this. In Malawi, the beauty of that model is that we looked at how we expanded scope of practice for nurses and community health workers to do what they could be trained to do, and they practiced at the highest level of their training, education, and credentialing. We trained community health workers to do all the reception of patients. When they come in, they did the intake, they did the triage, and they did the vital signs. Nurse practitioners did the prescribing. Complex cases got referred to the physician, who would come on a regular schedule, but the clinic was a nurse-managed clinic. We developed an electronic health record that connected to the pharmacy, the care, the outreach worker, and everyone was getting reminders through shared cell phones, ironically. Even in rural areas, they're relying on their smartphones. So usually it's just a burner phone. But it can work. In rural communities like that, and rural communities like what we have here in the United States, we know that there are models of care that are successful and they can work. So last but not least, because I'm getting the evil eye of Lieutenant Commander Santiago, a few take-home messages I wanted to share with you. We need to invest more in building resources and building the levels of the federal government around access to health and quality of care. We know that quality of care for all is the only way we're going to level the playing field. We need to shift from a sick care system to a prevention system. And that means that every provider in every sector, whether it be housing, healthcare, or food and safety, food security, we need to find models that we can connect everyone through case management or outreach workers in rural communities and in urban communities to be able to have access to the care that they need. Public health is not just a clinical care. we need to remember that determinants of health play a key role in the public health system. Public health is everyone's responsibility. We all have a stake in the game. And I want to say that approach succession planning as an obligation. So every last one of us in here should have a mentee and a few interns that we're dragging along behind us to take our place, because it takes a lot to recruit, mentor, and develop the next generation of healthcare providers and healthcare leaders. And we have a lot of them in this room. I feel that our healthcare in this country is in very good hands. If this is an example of what we have to rely on in the future, one of you may have to take care of me one day. I think we're in great hands. But I know that there's a lot of work that still has yet to be done. We need you to find your place at the table, take it, and be relentless at advocating for your communities and advocating for public health. I want to thank you for the opportunity to be here tonight. It's been an honor and a privilege to be here to participate in the Littlefield Lecture. And ma'am, thank you again for all of your work, and thank you, Dean Scott, for the opportunity to be here. I have one more thing, one more item of business, because I am at that age I'll forget. So Dean Scott, I want to share something with you. In the military, we have when you make the flag, you get these things on your arm. You get to have your own personal challenge coin. In the military, we share challenge coins as a sign of respect and gratitude for excellence. And there are so many wonderful people, so many wonderful leaders in the nursing community, but you are a stellar leader, and I want to thank you for the invitation to be here. I want to thank you for all that you're doing, not only for the University of Wisconsin at Madison and across the state, but what you're doing as a representation of excellence in nursing across the world.
Thank you very much. Thank you. Thank you, Admiral Trent-Adams. We do have about 10 minutes for questions. We have microphones on both sides of the auditorium. Remember, we are doing a live video stream, so we want our colleagues in Eau Claire and in our active learning classrooms to be able to hear you. So I would ask you to raise your hand, and we will hand you a mic. And so please, anyone with questions?
We have just learned from the UN that climate collapse is going to be upon us with greater fury and sooner than maybe we expected, well within our lifetimes. So my question is, when it comes to public health and community health, what are your thoughts on how we're going to address this?
Thank you. We talked about this a little bit earlier today, and I think that one of the things that's most important to remember is that regardless of what any one individual has to say, the science is a science, and we must address the science for what it is. It is the basis and the foundation for the research that's been done in this area. Now, I also want to look at this from a participatory perspective. In the roundtable, this question came up about what can we do to impact climate change. And there are a couple of things that I mentioned then, and I'll reiterate them now, is that we all have ownership in public health. We may not be able to change the masses with our voice, but we can with our actions. And how we participate in the process of policy change is up to us. Now, there are things that we can do individually, collectively, and within the community. I think that we have an obligation around as it relates to climate change and the research based on an individual's perspective, using the research as well as the information that's provided from across the world on how lessons learned have improved climate change or improved standards of air quality and water quality. Those are the kinds of things we should be talking about. I do think that there's a great opportunity for us individually to take on that role, to look at what is it that we can do to make those changes, and how do we advocate and educate decision makers and stakeholders about how we feel about the situation, and instead of focusing on one individual process or one individual approach, I think we all have an obligation to look at this from a more global standpoint. We know that if you keep doing the same thing you've been doing over and over again, not much is going to change. So we need to look at this very differently. If you could do one thing, or if you could do a series of things within a community, what would that one thing be? Are all of us driving hybrid vehicles? Are all of us using solar-powered, using solar panels to generate power within our homes? Are we educating the children about solar and using other resources and decreasing their carbon footprint? Because that is how change is really going to happen. We may never convince some people that the facts are the facts, but we can make an impact on behavior. And action speaks louder than words. At least that's what I was taught.
Rear Admiral Trent-Adams, thank you very much for your expertise and your commitment. I want to make an aside. You may need to explain to Dean Scott what happens when you ask her for that coin and she doesn't have it on her. My question to you, ma'am, I knew a bit about the Ryan White program because I lived in California when the epidemic broke and then waited to see what would happen. I have a strong conviction that the lessons learned from that program have broad generalizability. I'm not certain the story has been told. You have thoughts about that?
I sure do. This is my favorite topic right here. So let me tell you, we just had a conversation recently with the Assistant Secretary for Health. He was doing this presentation on, he has his vision is changing the map, okay? So he wants to take a healthcare issue, and that's been devastating an area for some period of time, getting the data, figuring out what is the problem, and what are the resources in that problem, and he's basically doing a root cause analysis. And so he said, well, how do we change the map there? If it's childhood immunizations, if it's diabetes, if it's cancer, how do we change the map? And I said, I know how you can change it. There's a model that really works, and it works very successfully. And the basic principles of that process indicate that you can make changes in behavior, you can make changes in the system if you engage your community, use the resources that you have to the maximum ability, but you have to be transparent about where the resources are, and you figure out who's willing to play and who's not willing to play, and you figure out how you leverage all those care delivery resources to be able to get to that comprehensive model. And he said, well, what are you talking? I said, basically it's the Ryan White Care Act model. And the Ryan White model involves everyone in the community to set priorities, to identify where the resources can be spent, and they engage the community and identify stakeholders to have a voice in the process. Now, is it perfect? Absolutely not. But you can make headway on large goals and objectives incrementally, because I never thought we'd get to viral suppression rates in the 80s, in the 80% range. I really didn't, because very early on we were in the 40s. We've made significant progress with antiretroviral therapy and having open formularies and being able to support that comprehensive model of care. You can write all the prescriptions all day long, but if a patient becomes drug resistant, what good is it? You have to have that follow-up, that model to have comprehensive services. So I do think it's an untold story, but hopefully not for long.
Thank you so much for your presentation. It's wonderful to hear. I actually work for the Wisconsin Division of Public Health, so I do not have a nursing background, but I am grateful to Dr. Susan Zahner for forwarding this information to me and my colleagues so that I could be here. What I'd like to hear a little bit from you on is an action step. For those around the room, we have some incredible folks in this room who are learning about their new career, in the early stages of their career, advanced in their career. And we know that public health is based on, it has nursing at its foundation, at its core of the services that are provided. So maybe one, and if we have 30 seconds for two, maybe action steps for folks to think about as they enter into their career in nursing, as they go back into the workforce, and say, I see this, I can connect that to public health and what I heard here.
Okay, so very quickly, the most important thing for any nurse in any setting, know your population. Know who your patients are, know where they live, eat, sleep, and pray. It is important for you to know who they are and how they function to be able to best meet their needs. That's the first thing. From a professional standpoint, from a developmental perspective, and this has nothing to do with nursing or public health, but has everything to do with nursing and public health. Get a mentor now, and always have a mentor in your career. And when you get to a point that you have some lessons learned, reach back and mentor someone else in the principles of public health, in healthcare delivery, and understand the importance of interprofessional collaboration, but more importantly, training. When you train together, you can stay together. Divided, you stand, united you stand, divided you fall. I think that the same goes true for training in the workforce of healthcare. We have to become more collaborative in our spaces because we don't know how the other one thinks. When I was thrown into the mix with working with social workers, I didn't know they did everything that we did, but we did a little bit differently. So you can create some economies of scale if you're working together in a team, and understand that you need to be developed as a part of that process as well.
So I know that you may have more questions. Unfortunately, we are out of time because even I felt Lieutenant Commander Santiago's look. So.
She has a radar that like goes through my brain. I thought. Yeah.
I know. But please join me again in thanking Admiral Trent-Adams for being here with us and